Okay, so the idea at this conference when we were planning was whenever we talk about CTRT consolidation, we talk about durvalumab, durvalumab, durvalumab. The idea was that we have some data coming, and Minit rightly showed the data from gemstone study for sigulumab, and we don't have access to that molecule. So in durvalumab, it was for 12 months. In the gemstone study, it was for 24 months. But I'm going to show you the small data, which was from a randomized study of BTCLC, in which we had used nivolumab, ipilimumab versus nivolumab. And this is what was the background, that up till now, whatever is talked about is consolidation with durvalumab. We have not talked about any other agent can be used, and what is the optimal duration. Do you need to give it for 12 months? Do you need to give it for 24 months? And or you can cut it short to 6 months. And that exactly was one of the questions in this study. Interesting design. It's a small phase 2 actually. You could see that the patients who had stable disease or response, PR or CR here in the lower part of the corner, they were the patients who were randomized. They were randomized to interesting schedule. One was nivolumab, 480 mg IV every 4 weeks, only for 6 cycles. So that means only 6 months of treatment. Vice versa, giving nivolumab 240 mg every 2 weeks, plus ipilimumab 1 milligram per kg every 6 weeks, and this is considered as a 1 cycle and 4 cycles of such. So here we are comparing 6 months versus 6 months, 4 cycles versus 6 cycles, and the agents are, in one agent we are giving only nivolumab, one is we are giving nivolumab and ipilimumab. And we can argue there is no placebo arm here. We can argue that there is no standard durvalumab arm here, and that is one of the limitations of the study. Small study of 50 patients each, and it shows that there were approximately well distributed factors between both the arms. The interesting thing is in the treatment received. If you see that most of the patients on an average completed the planned duration of therapy, but you looked at completion of 24 weeks of treatment, you could see that there is a startling difference. Even nivolumab in that dose was completed by only 76% of the patients. And when you combine it with ipilimumab, it was completed by only 56% of the patients. So there is a difference in compliance there, which didn't reach statistical significance as the numbers were very few in this situation. And why was there a difference in the compliance? And that difference in the compliance was because of higher rate of adverse events, which happened when you combine nivolumab with ipilimumab. There was a higher grade of grade 3 and 4 events, and as we all know, a higher degree of colitis, which immune-related events which were related to GI, which was seen with addition of ipilimumab. This actually was, when I planned the meeting, I thought that this would come into full text. Actually, it was a poster and ASCO. And in the ASCO poster, they didn't give any curves about the survival. In the abstract only they had given figures, so I'm sorry I couldn't show you the curves here. But what was their basis was they looked at 18-month PFS. And if you could have seen what Minit was showing you is 18-month PFS around 45 to 50 is where you would see what we achieved with durvalumab. What was seen here was that similar amount of PFS, in fact slightly on the higher side, was achieved here. It was 62.3% on the only nivolumab and 67% on nivolumab and ipilimumab. What this also shows is that even if patients who received nivolumab and ipilimumab, they had to receive only 4 cycles. Only 56% could complete all the cycles, but those 2 or 3 cycles which they received, that was effective enough for you to get an 18-month PFS of 67%. The median OS was not reached in both arms. In fact, if you could see the 21-month OS, it was 76% in one arm and 82.8% in one arm. And if you could remember what Minit had showed, it was around 60 to 70% in both the gemstone and the Pacific study. This is a small trial, but this gives you a food for thought. If the patient cannot afford durvalumab, if you don't have access to sigulumab, if could we offer on compassionate ground nivolumab to this patient, which will be only for 6 cycles in this patient, and can we get this advantage in this? So this is what they concluded, that these controls which they achieved seem to be better than what was seen in Pacific. The OS data is still immature, but it still seems promising at 2 years. And there need to be further trials in this setting where we need to see which among this agent is the best, and whether we actually need to give a 1 year or 2 years of consolidation, or probably a 6 months of consolidation, or probably if you go give something like Nivo or Ipi, a 3 months of consolidation, it would be enough in this patient, and which might be more relevant to our country. And that's it. If there are any questions, I would be happy to take. Thank you.
I think questions will take up during the panel.
Thank you, sir.
Thank you, Vijay. Next is real-world experience evidence of durvalumab in stage 3 non-small cell lung cancer, Pacific R, by Dr. Rajit Channa from Delhi.
Morning, everyone. So we'll be discussing the Pacific R, that is the real-world data of durvalumab maintenance. So this was presented this year in ESMO Immuno-Oncology meeting by Gerard et al. So the Pacific trial had some questions raised that whether it is actually a new ocean or it is an abnormal wave. The points against that were that the PFS in the control arm in the Pacific was less as compared to the standard Proclaim and RTOG 0617 study. PET CT was not mandatory. The dose of radiation was not standard. It varied between 54 to 66 gray. They didn't mention that 60 was the standard, and they didn't allow sequential chemotherapy followed by radiation. So, it's always better that if we have a real world data of a standard phase 3 study that helps build us confidence. So this was the background of this study. So it was based on the phase 3 Pacific study that durvalumab as consolidation therapy for up to 12 months, it has become a global standard of care. And we have the 5-year data. The 5-year OS is 42.9% versus 33.4%. And real world evidence is needed to confirm if the benefits seen with durvalumab in Pacific translates actually into routine clinical practice. So this is the first planned analysis of the overall survival from the Pacific R study. And these patients got the drug through early access program. So it's an ongoing observational retrospective study. The inclusion criteria was similar to the standard Pacific. The patients received durvalumab through early access program, and the data was extracted from patients' medical records. And the final, the estimated OS is due in late 2023 and 2024. Majority of the patients, they were from Europe and Australia. So as of 30th November 2021, the final analysis set included around 1150 odd patients. The median follow-up duration was 38.7 months. The primary endpoint was PFS and OS. So the patient characteristics, they also included patients who were more than 75 years, and sequential, those patients who received sequential chemo-RT, they were around 15%. PD-L1 expression more than 1 was present in 72.5% and less than 1 was present in 17%. Majority of the patients were non-squamous histology. Stage 3B or stage 3C were around 53.6, rest was stage 3A 46.4. So coming to the overall survival, the 3-year overall survival, the OS has not yet matured, but it is more than 60%, around 63.2%, and the outcomes, they were numerically better among those patients who received durvalumab within 42 days of finishing RT. So you can see from this table that the 3-year OS in those patients who received within, within 42 days, it was more as compared to those who received less than 42 days. That is around 66% favoring less than 42 versus 61.8. Similarly, the PFS also favored those who received within 42 days. And the median PFS at 3 years was 45.5% and 40.3%. And the outcomes were numerically better among those patients who received concurrent chemoradiation therapy as compared to sequential. The 3-year OS was 64.8% versus 57.9%. So, this trial, this real-world study had some data that even if the patient is unfit to receive CTRT upfront, there is a role of durvalumab maintenance. But obviously, the benefit is more if the patient is receiving concurrent chemoradiation therapy. And the data is comparable with the standard Pacific trial. So this data that they have mentioned is from the December 2021 update. So the 3-year OS was 64.8% in the Pacific Real and 56.7% in the Pacific study. And in the sequential CRT that was taken compared with the Pacific 6 study, which was a phase 2 trial of durvalumab single arm. So the 3-year OS rate was 57.9% in the Pacific R, and it was not reported in the Pacific 6 study. So as expected, the outcomes were better among those patients who had PDL1 TC score of more than 1% as compared to PDL1 TC score less than 1%. 3-year OS being 67% as compared to 54.4%. And this study had comparable results with the standard clinical trial data according to PDL1 status, comparing to the Pacific study. In those patients who had PDL1 TC score of more than 1, it was 67% as compared to 61.9. And if the PDL1 score was less than 1, the 3-year OS was 54.4% versus 47.5%. So obviously it had some bias because it was a retrospective study. So some information for patients who died before enrollment opened could not be collected at UK and German sites. So, this was a study which was published in May 22. So it showed that durvalumab consolidation in patients with driver genomic alterations. So this study showed that the benefit of adding durvalumab in those patients who had driver mutation is not that statistically significant, except in those patients who had KRAS mutation. So, durvalumab should be given only if we know the baseline mutation status of the patient, and those patients with EGFR, BRAF, ALK mutation should not be given a durvalumab consolidation. Those harboring KRAS mutation did show statistically significant benefit. So conclusion is that the Pacific real-world data continues to provide evidence for the effectiveness of consolidation durvalumab after chemoradiation therapy, and favorable real-world OS and PFS results, they were absorbed across the clinically significant subgroups. And these outcomes support the continued use of durvalumab consolidation after chemoradiation therapy as a standard of care for patients with unresectable stage 3 non-small cell lung cancer. However, I would like to say that in those patients who have unresolved pneumonitis, they were not included as a part of the study. So those patients who have grade 2 or more pneumonitis should not be included, and those patients who have presence of EGFR, ALK, ROS1, BRAF mutations, they also should not be given durvalumab consolidation. Thank you.